Okay, the next question. It's a good question. How do these are all great questions. How do oncologists determine what treatment I should start with, and does the order affect the outcome? Go for it, one of you. I'm assuming this is maybe in myeloma, but this is pertinent to
Sure.
lymphoma also. Yes.
I'll just take a 1-minute stab at this, and because I think especially for myeloma, there are many factors we consider for determining treatments and in between immunotherapies as well. First of all, patient factors, disease factors, and environment factors. Patient factors, you try to always see what is the performance status, and that's so important. We all keep harping on about performance status, but that has a huge amount of importance into the type of treatment we will plan for you. Your history of infections, how you've responded to treatments in the past, all that are taken into consideration. And for disease characteristic, what all drugs has the disease kind of been exposed to, inherently is the disease exhibiting signs of high risk versus standard risk. And some of the environment factors as well, logistical support, family support, because for some stem cell transplant or CAR Ts, these are also important considerations. And now regarding conventional chemotherapy, we have a lot of data that shows after certain classes, these particular classes work. But if your question is particularly with, do CAR Ts need to go first or do bispecifics need to go first? We now have data coming in, although that's not changed anyone's practice yet. But, the 4 out of the 5 approved CAR Ts are right now, immunotherapies are right now directed against BCMA, the B cell maturation antigen. So there's a lot of talk happening at all our conferences in what is the right sequence to do this. There's a whole lobby of patients of doctors who are like, those who are CAR T eligible should get CAR T first, and then if progress should go to bispecifics and vice versa. But there's recently a paper that came out maybe a month or 2 ago that looked at what is the percentage or what is the amount of this BCMA that's present in the cancer that comes back after it's been exposed to either CAR T or bispecifics. And the punchline is that the researchers, at least for the number of patients they looked at, they saw that the amount of BCMA protein that was expressed was a little bit lower in those who had bispecific antibodies, and that's been thought of or postulated because of the continuous mode of administration. So at this time, there is this theoretical evidence that the same target CAR T following a bispecific may not be as effective. However, that hasn't really changed our practice yet, and we are still on the lookout for this data. But again, primarily we decide by looking at all these factors.
Okay. Yeah, we don't know how to optimally sequence in myeloma. And sometimes some other factors, like it's how fast is the disease progressing? I mean, this patient has rapidly progressive disease. I might not have the 2 to 3 months to wait for the CAR T to be manufactured and have to do something more urgent. So that goes into also.